So welcome to another dose, the GEMS podcast where EMS meets ED to talk about trending topics in emergency medical services. I'm Dr. Candace McDonald.
I'm Robin Goldinger, and today's show is focused on personal mental health and EMS providers and healthcare workers.
So our EMS first responders, we know that they have a huge heart for helping others, but sometimes they struggle to take care of themselves. First responders are generally considered to be at greater risk for mental health disorders than most other occupations because of the routine exposure to traumatic stresses.
Our EMS personnel and our emergency department workers face challenging and traumatic events that can impact their mental well-being every day. In addition to patient needs, their family needs, long work days, nutrition, physical health, sleep deprivation. Those night shifters never sleep right. Nurses never get to pee or eat. So, we're always pushing through, and neither does EMS. They get that crappy sandwich in the EMS break room. But those all have a huge impact on our sense of well-being and our wellness for health.
Yeah, and our health professionals responding to the COVID-19 pandemic have also experienced an increased stress level over concerns about exposure to the virus, having to self-quarantine, and the health and safety of their own family. So we know that's an issue as well. We know that mental and emotional wellness is critical to the longevity of health of a healthy EMS career. We know that mental health issues impact the retention of our EMS folks. So let's take a look at the research. What we know is that an estimated 30% of first responders develop behavioral health conditions, including but not limited to depression, PTSD, and that's compared to the general population that only sees about 20%. Our first responders are always on the front line facing high, stressful, and risky calls. One study actually showed that 69% of EMS professionals reported that they never have enough time to recover between those traumatic events. So that tends to result in depression, stress, suicidal ideation, and a host of other functional and relational conditions. And that's what our EMS folks are reporting. So another study suggests that EMS personnel may be more likely than the general population to think about and attempt suicide. It was reported that 37% of fire and EMS professionals have contemplated suicide, which is nearly 10 times the rate of American adults. So it's definitely something that we need to take a look at and figure out how we can address and how we can help our providers.
Today's podcast, we will look at interventions to reduce behavioral health risks for our first responders. We'll speak with guests with different tools to address the issues. First, we'll speak with members of a peer support team, followed by a clinician. And finally, we will chat with a department chaplain.
Yeah, so first up, we have Tracy, an advanced practice paramedic in North Carolina and one of the coordinators for the North Carolina Peer Support Organization. She'll be joined by Captain Dina Alley, former police officer and current firefighter. Dina has spent a great deal researching firefighter suicide, and she's the founder and director of the North Carolina Peer Support Organization. I've had the opportunity to hear Dina speak at conferences across the country, and she's so passionate about what she does. And we're going to go ahead and we're going to start with Dina first. So Dina, we know that first responders are always at the forefront of each and every disaster. They're out there trying to ensure the safety and well-being of the community. And earlier I shared some statistics from the U.S. Department of Health and Human Services about mental health and our EMS folks. What trends are you seeing that led you to found the North Carolina Peer Support Organization? And can you tell us a little bit about what your group does and how it's addressing the issues that you're seeing?
Hey, Candace, thank you so much for having me. I really appreciate it. And one thing I left out of my bio, I actually worked 11 years with Wake County EMS. That was my part-time gig. So it's kind of, I have a familiarity with like all three of the big public safety groups. And what I noticed is, there's so many differences with our stressors, unique types of burnout, unique types of experiences. But one thing that's common for all of us is we're human and we experience stress in our lives just like everybody else does. However, the commonality I found that can lead to negative outcomes is some reason when we become first responders, when we get released to practice or, we're out on our own, we feel like our jobs are to be the fixers. Our jobs are to be the helpers. And in that role, we feel that we can never be somebody who needs help. But the crazy thing is, I mean, our careers are 30 years long. We start in our young 20s. We go through life. We have so many life experiences. And we've got to be able, when we are feeling depressed, when we are feeling anxiety, we've got to be able to express that to somebody. And what ends up happening is we feel shame because we look around and we think everybody's handling it so well and everybody's perfect and nobody has these experiences. So we bottle it up and we find those maladaptive coping strategies. We know alcohol is the number one strategy, risky behavior, other types of negative behaviors, and we engage in those, and that kind of puts us further down that negative path. So, you know, when I first got involved in this, I looked at the data and the statistics as well. I looked at, man, are our rates higher than the general population? Are we affected uniquely than the general population? And even though a lot of the data that you find might make us feel that way, I haven't found any data that controlled for gender. I haven't found the data that controlled for race. And so, you know, for example, for firefighters and police officers, a lot of times the data comes back and it's like they are 5 times more likely to die by suicide. Well, the population dying by suicide at the highest number is the white male. And both of those populations have a lot more white men than everything else. So me personally, from what I've reviewed and what I've looked at, I don't think that our numbers are that much higher than the general population. I do believe, and I have seen certain mental health disorders that are more common for us, and especially the adverse responses and effects of sleep disorders.
Yeah, so how did you end up starting your group, the North Carolina Peer Support Group? What led you to starting that?
Ooh, I don't think we have enough time for all that, but I'll give a very quick synopsis. So in 2015, I got promoted. It was my first like major step within my department, and I was assigned to a SLO firehouse. So I did all this work to get promoted. I was so excited. I thought I was going to go and practice my skills and lead people and do great things. And then I went to a firehouse that averaged maybe 3 calls in 24 hours. And my whole crew had more experience than me. So it was kind of like a big slap in the face for me. But I recognized at that time I'd been out of school for a while. I was writing reports and I didn't know where to put commas and whatnot. So I was like, I should probably go back to school. So I started graduate school. And oddly enough, the way life works is I actually ended up in a depression that fall. I was really depressed, but I was in denial. I remember going to see my primary care physician and having them check my, you know, all my levels. Maybe I was having fatigue. Maybe my, you know, I thought that, you know, cortisol was off, or, yeah, I had all these things checked and nothing was off. And I just kept denying the fact that I was depressed. So I was depressed. I had a combination of factors, personal, work-related. I was dealing with a bullying issue, individual that was being extremely disrespectful and harassing, with a company officer that wasn't handling it because it was uncomfortable. So that made me feel like it was my fault. And I got even more depressed, and there was shame with that. So I didn't talk about with anybody. I was kind of humiliated by the situation, and I didn't want to, you know, be like, hey guys, you know, Tim's being mean and it made me depressed. So I bottled it up even more. And then I started thinking about suicide a lot. And ironically, that semester, my assignment was action research. You know, find an area where current practices are not best practices. Research help develop better practices. So I emailed our safety chief and asked him, you know, what's an area I can research? And I had no idea he would ask me to look at firefighter suicide. I thought it would be, you know, something like, you know, survival, Mayday, you know, something that is cool. But he had me look at firefighter suicide, and this is 2015. This is before anybody's really talking about it. I remember I'd get the research, and I would I'd be at the firehouse, and if people would walk by, I'd turn it upside down because I didn't want anybody to see what I was looking at, because they might, you know, think something. But as I got involved in the research, and Dr. Sabia's dissertation that she wrote in 2007, and it is so applicable today. I recommend anybody interested in this, look at Dr. Janet Sabia's dissertation from 2007 on firefighter suicide. She actually looked at every death certificate of every firefighter in North Carolina over a 15-year period. and compared those rates. And it was fascinating, the amount of data that she got from that. But what was so fascinating to me in her study was she found that it wasn't trauma, PTSD, the big things that were impacting us. It was actually the silence that we feel is necessary when it's the little things that we have shame from. And she noticed, members being ostracized, members, suffering from addictions, things that are, somewhat humiliating. And those experiences making them isolate themselves, suffer in silence. And one of the common things that she found was, and this is something I experienced, and maybe it's why I connected so much to the research, was she found that, we see our problems and we're like, they're not worthy. There's people with real problems. What I'm dealing with is so silly. So we close off. And she did a lot of research on Dr. Joyner's theory of suicide. And in his model, very simple model, he found that two things that are necessary for the will to live are connecting with others and having purpose. And so as I got into all the research, look at all the evidence and whatnot, suicide is complex. And so there's no solution. All mental health, addiction, all that, it's so complex. There's no one size fits all model that's going to help everybody. But one thing that I found common among every disorder, every issue that we face, is the need for meaningful social support. And by meaningful, it's not just, having a superficial conversation, but actually being able to open up and express those things that, you feel shame from. And what makes that meaningful conversation so much better is having somebody who will listen without judgment and even relate. So that's where peer support kind of, evolved. The Illinois firefighter peer support team, they put together their team in 2012. I thought their team was amazing. So I kind of looked at the work they were doing, and it was just such a simple concept. It was people who experienced adversity having the courage to say, this is what I experienced and this is what I did to get better. And then it was all of us learning ways to cope, learning about, clinicians, therapies. And so peers become, first of all, just a resource for listening, but more importantly, they learn resources, and they are simply a bridge between somebody suffering and all the many wonderful mental health resources, or even financial resources if needed, parenting resources. And they're that connection to those resources. And what we learn makes it work and makes it better is when the members who serve as peers have utilized the resources, have gone through something difficult, have gotten outside help, or have found their way through, and they're willing to express that and share it. So when I saw how important peer support was, I knew my experience and how painful it was. And I guess, what I went through, it sucked at the time. It felt silly, but I got on this vengeance, I'm going to find a way to help other people. And I'm going to solve, I thought I was going to solve the whole firefighter suicide problem. But the ball just kept rolling. It kept growing. And, our peer support team started with our agency. And then we realized people are not comfortable talking to other people with their agency all the time. There's a lot of gossip. So we were like, hey, let's create a triangle peer support. And initially it started out as just firefighter peer support. But then we recognized, and Tracy's a big part of it, that other first responders in law enforcement, in EMS, they bring specialized skills and talents. For example, in Wake County, our EMS system is so advanced, and we have the advanced practice paramedics. And now almost all the paramedics are getting the crisis intervention training. So they have that additional training, that additional understanding of mental health, of crisis. And then on top of that, our law enforcement, they're doing the same thing. They're getting the crisis intervention. So we realize that if our team includes fire, police, and EMS, and now telecommunicators as well, we're going to have all this knowledge, all these resources, and no matter what somebody's dealing with, we're going to be able to find a way to get them the help that they need.
It sounds like it's definitely a great needed program that you guys have created.
It's been really cool watching it grow. It's been amazing.
So this question is for Tracy. How can we get our listeners to be able to create some kind of program like this? We have listeners from all over the country, so I think this is awesome, and I'm thinking about how I can initiate it in my emergency department. I think it's an awesome tool.
I
think this is probably a pretty decent question for Dina to answer, just because she had created the actual peer support program. But we do know that there's different types of peer support all around. And Dina, if you want to jump in, you can at this point. But our team is very specialized with how, Dina created it. And I'm one of her coordinators. And so in the central part of where we're at right now, if there's an issue or a need, I'll, try and handle it in that way. And we can kind of go and use other people's teams. There's teams that are focused with law enforcement, teams that are just dispatchers, teams that are just firefighters. And thankfully, Dina and her team, or our team, and also a lot of the people that she's politicked with and learned from, they kind of tell us, oh, we have this team over here. We have some nurses that, have this private little team together where they support each other. Or we know of, other people who have something similar. They just don't have a name for it. And that way we can kind of encourage them, show them what we learned, and kind of just encourage them on that basis. It's not that complicated, just to be able to have a conversation with someone else. Dina, did you want to add something on actually building the team?
Yeah, do you guys want me to jump in on that? I don't want to dominate this conversation.
No, yeah, go ahead, share. I think it's important for those in other states and other areas to learn how to build that peer support team. So yeah, please share.
So our team started, like I said, just with the city of Raleigh, just with my agency. And I hit roadblocks. The administration, the major roadblocks were, oh my God, liability. What? And I remember I had a chief tell me, he's retired now, so I can call him out. I had a chief tell me, he said, what if you guys talk to somebody and then they kill themselves? We're going to have so much liability. We can't do this. And I got frustrated by that. I just got very frustrated by it because to me, it's more liability if we know what's needed and we're unwilling to do those things. So I created our nonprofit. So our team, our statewide team, is actually a separate entity from any organization. It's North Carolina First Responder Peer Support. It is a North Carolina 5013 nonprofit team. And it was kind of neat starting it because at first, like Tracy said, we work with other organizations. We have an organization called NC LEAP, North Carolina Law Enforcement Assistance Program. They are incredible. They are fundamentally and primarily CISM, Crisis Intervention Stress Management, but now they do a lot of peer support. So when we first started, I remember they told me, they were like, this is not a national standard. You can't do it. And they kind of rolled their eyes at it and they were like, you can't do this. This is not safe. But then I started inviting them to the classes. We started working together. Tracy and I have attended their seminars and they started to see what we were doing. It was very simple. It was just letting people know that if you're struggling and you need help, reach out. And somebody be willing to talk to you. And a lot of times if it is a request that's a crisis or a critical incident, we refer to those resources. So how we started our team in our organization, the first step was training. We reached out to the Illinois Firefighter Peer Support Team because they were the only team that was traveling the nation providing the training. So we reached out to them for training. The International Association of Firefighters conducts training. And then I know there are some first responder support services and teams in Colorado that provide the training. Our team, North Carolina First Responder Peer Support, we provide the training. We'll actually be traveling to Loudoun County, Virginia in November. But we put on our trainings in North Carolina and we share the material. And so the first step was training for us. We had 30 members come to the initial training. And at the end of that 2-day training on active listening, on resources, those folks were considered peer supporters. And it's so simple. Asheville Fire Department, they're the ones that gave me this idea. They took a list of everybody who had the training and they wrote their names and phone numbers on a piece of paper and put it up in every firehouse. And just said, hey, if you need peer support, here are our members. Every team is different. Every team can do it differently. So at Raleigh, initially, they were a little weary of what we were doing, but then as they saw the buy-in that we got buy-in from our Office of the State Fire Marshal, from the North Carolina Office of EMS, and from the North Carolina State Firefighters Association. We got buy-in from all of those. And once they saw that, then they bought into what our team was and made our number available. And now we've done the same thing as Asheville. We have every member's name and phone number. We have it on a spot online, and we're gonna have those printed at every firehouse. But simply, I took a class. Do you guys know Sarah Barnes? She does a lot of research.
Yeah.
So I listened to her talk about peer support at a conference once, and she explained it better than anybody else. She explained it by using an analogy with the Manteo Incline in Colorado. If you've never been to this thing, it's 1 mile like climb upstairs, like an old railway. And there's this false summit. So as you're climbing, it takes forever to get to the top. As you're climbing, you see that summit and you're so excited. But then when you get there, you realize you're just a little over halfway. And there's so much more. And she said that's kind of how peer support is. Every department, what I've seen is they want to have all these pieces in place. They want to have trained peers. They want to have clinicians. They want to have resources. They want to have everything possible before they consider themselves functioning. And in doing that, they never actually start. And what I see is people get the initial training and then they lose interest because nothing happens. That's kind of what started to happen in Raleigh. But what Sarah said and what I learned and what I realized through my experience is it's just going to grow. You're not going to have all the pieces in place at first, but be patient. Work with other departments around you. Work with those resources. Reach out. Us with our team, one thing that we do, once we became a nonprofit, we got a telephone number, a Grasshopper account with that telephone number. We made it available so anybody can call, but nobody answers it because Tracy and I, we're on duty. We're first responders. So immediately when somebody calls, the voicemail says, very compassionately, thank you so much for reaching out. Thank you for calling. Somebody will get back to you in a few minutes. And we're really good about that. But also we say, if you're in crisis, press 0 now and you'll be transferred to the Suicide Prevention Lifeline. So we have that ability for somebody to call 24/7. And if they are in crisis, to get that resource. And that's one of the things I realized is it's about networking with other resources, knowing how the Suicide Prevention Lifeline works, and knowing that if you are a peer support team, the weight's not all on your shoulders. If somebody's in crisis, get them to the right resource, but don't delay, putting a team together because you're afraid. If you've got people who are willing to attend the training and willing to be there for others, have that team, and slowly more people will get on board. It's been amazing watching what's happened in North Carolina. We started with one class of 30 trained people in one area on one, no, actually we had 4 departments show up that day. And now almost 4 years later, we have over 300 people trained. We've had clinicians come through the class, telecommunicators, police officers, EMS, firefighters. And now we have that many resources, and we conduct our own training. Before we started doing that, I attended the Illinois class, and then I attended the IAFF's 2-day class. I finished my master's where my focus was on suicide prevention. I took all the best information out of those. I sat down with Chief Dan DeGrice, who helped write the curriculum. He looked over what I did, and we created our 2-day class. And I believe that anybody can do that because training's expensive, training's hard. You just have to have the confidence, and you have to have somebody willing to do that work to be able to do so. And one thing that we do, or one thing that I do, is I share my information with other people. If somebody wants to sit in my class and then they want to provide that training in their region, I share my information. And the one thing I do say though is if you take this and then you charge money for it, I'll come after you. But I want people to be able to do what we're doing. Because right now that I think that is the most difficult piece, is that there's not a lot of training out there, and the training's expensive. The IAFF, it's like $9,000. And I think Colorado's, that's one of the only places I know that's doing training for first responder peer support for EMS, other than what we've got in North Carolina.
Yeah, that's good information. And I think, one of the things that I like that you said is that as a peer supporter, you're that bridge to get that person to somebody that can help them. And sometimes it's easier to ask somebody that you're familiar with, hey, how do I get linked to a resource? So I think it's great that you're training your peers on what resources are out there and how to connect people. So thank you, Tracy. Thank you, Dina, for sharing about your program. I think it's good work that you guys are doing. So thank you. Next, we want to move over. We want to move over to our clinician, Yvette Graham. She's a licensed independent social worker. She's worked for over 30 years assisting families struggling with issues related to mental health, substance abuse, child welfare, criminal justice, and education. She's been identified as a key partner for the County Community Health Improvement Plan in Ohio, and she's been called upon by numerous federal agencies to serve as a subject matter expert. So Yvette, the first question that we have for you is, can you talk a little bit about what secondary trauma is and how it impacts our first responders?
So secondary trauma is also known as vicarious trauma. It's the experience of being around or near or knowing a situation where a trauma has occurred. You may not be involved in an accident, you may not be involved in a suicide situation, but the frequency in which you encounter it kind of builds up. And I know Dina was talking a little bit about having those little things that happened to her that bothered her and how they accumulated. And that's a good description of what it means to be in a secondary trauma situation. It builds and builds and builds until it becomes something that's unmanageable, and it can create a situation where you're in depression, experiencing PTSD symptoms, and really need to be reaching out for help. A lot of times it's minimized because you're thinking that it wasn't my trauma, it wasn't my incident. A good example may be in this situation, dispatcher who gets calls. So they're getting a call about accidents, or they're getting calls about shootings, or a lot of different things. And it's usually left that way. So they have this heightened awareness of all these traumas and know where to put it. And so it builds and builds and builds until they experience depression or PTSD and then need help themselves.
Yeah, that's, I think it's important because what you said is that, and I heard Dina say, is that a lot of times we minimize and we don't think our problems are big problems, and then they build and build and become really huge.
But how should our leaders go about connecting their employees to some mental health services? And when do you think that it's most valuable to people after the incident? Is it right away? Is it a week later? I'm asking kind of personally for myself, being in the ER with some pediatric codes. My young nurses that are, moms with little kids, they have a hard time with those. We had a coworker that arrested in our department, and we worked him and he passed away. That was really, really hard for the staff. What's the best way to address it? Is it that at that moment or later? But does that rehash it all?
So I think that the best way to address it is by beginning before it happens. Start those planning sessions. The leaders can think about how can we help our staff, our employees, our volunteers to go through these traumatic episodes, and through education, talking about what it is to experience trauma and how you can manage that with some self-care, or manage it with reaching out to resources. So it really begins before something happens. So if you do all of that, and then when the incident occurs, making a plan to have a time for them to debrief, a way to unload or vent, or more or less just get rid of express those feelings of anger and hurt and just fear sometimes, because it can trigger a lot of different emotions. So immediately after, and it's not just that same day, but maybe a week later, touching base, or 2 weeks later, touching base with them or your staff as a whole, to make sure that they're okay, that things are progressing, I guess is what I'm trying to say, back to a normal, manageable situation.
So what are some things that we should watch for in our fellow team members that might tell us that something might be wrong, that they're struggling? What are some of those signs and symptoms?
So they usually start small, maybe withdrawing, a change in behavior. They may get more anxious over small things.Maybe something may happen that you may see as maybe a minor irritant, but they see it as a big explosion or a major event. They may start missing work. They may withdraw. Just a change in behavior. You want to be on the lookout for those things where they're just not themselves, and they're not themselves for a week, 2 weeks, 3 weeks. And it's okay to say, I see that, you know, you're really getting upset over things that you may not have gotten upset over before. How can I help you? Just asking them directly. And if it escalates to the point where you're really concerned about their mental health or suicide, you can ask them if they've had feelings of harming themselves. Being direct is what they need to hear from you, that you're interested in what's going on with them and you're expressing a clear communication. And then linking them to services. I know that Dina talked a lot about the first responders not engaging in services. I mean, they're superheroes. You're superheroes in the emergency room, and you're superheroes out fighting fires and police officers. So that you have that kind of tough kind of exterior in a loving kind of way. And so it's hard sometimes for people in that profession to let their guard down with one another, to let them know that I'm in trouble. I mean, because they don't want people to know that they're in trouble. So it's okay to ask. I see that, you know, your behavior's changed. I want to help. I want to do whatever I can to help you through this.
Thank you. That's really, really good feedback. I think I can recognize some employees that could use a little TLC every now and again, and they do. They change in front of you. They're happy, smiley one day, and the next day they're another person. So I think being able to reach out to them and, hey, everything okay? What's going on? Do you need anything from me? Makes a difference to them. So thank you for being with us today. And we're going to go on with Chaplain Dr. David Mabry. Hi, how are you today?
Doing fabulous. How are you all doing?
We're great. Dr. Mabry has been in ministry since 1990 and has been serving as chaplain for Columbus Division of Police. Since 2015, Dr. Mabry and his wife started one another relationship in 2008 and have been on a mission to improve marital health of the first responder families. So welcome.
Yeah, thank you for having me.
Yeah, so I've known Dr. Mabry, Dave, for, over 20 years. I was actually in his youth group when he was an intern as a youth pastor, and I'm surprised I didn't chase him out of ministry because I was so bad, but that's probably why he has no hair. So,
that's right. That's right. And a lot of white and gray, and Candace is responsible for most of that.
I'll own that. So, all right, but we're really excited to have you here. I was hoping that maybe you could talk to our listeners about what a department chaplain does and the benefits that it has to the membership.
Yeah, that's a great question. And it's primarily what we would call a ministry of presence. And so a chaplain's role is not to Bible beat or force a religion upon constituents, people under their care or within their care, but more of a presence, and to speak to exactly what the conversation at this point would be talking about. Everything from just regular everyday life kind of issues that would go on. But then we know that within the sphere of first responders, there's a very unique audience group, collective group that we have here, and what first responders go through. And so a chaplain's role in that case would be very specialized to be able to be present in the midst of whatever they are walking through at a given moment, which we already know that it's whether it's hypervigilance or whether it is secondary or vicarious trauma, as what we've already discussed, or direct trauma. So add that to normal life that everybody out there faces already, from family difficulties to stress and strain, just normal in life. And so it's an individual chaplain that is able to be present in the midst of that and available to be some of the resources that have already come up that I love, whether it's a peer or someone from the EAP or counseling direction from a program. But chaplain would be within our program, it would be a third kind of leg on a stool for health and wellness within our division.
What's the best way to get a chaplain to engage with an organization?
Yeah, that's a great question because like I said, it's a very specialized chaplaincy or role because we know that there's chaplains for hospitals, for military, for nursing homes, but they're not all the same. And so it's a pretty strenuous vetting process. So for instance, I have family that are in law enforcement. And so with that background and the training that I have, that points directly to, and much to the experience, some of the same experience that Dr. McDonald and I shared from some of those days with trauma and some of the difficulties. Actually, to be honest, that's moved me into the ability to say, and hey, I worked in the midst of already facing trauma in a church background, and so move that then into, so that kind of my vetting process showed that qualification. And I'd say that we have 8 chaplains with the Columbus Division of Police, and every last one of us have some specialization. So that being said, to become a chaplain or go into that or to engage a chaplain, it's finding someone that is already has the ability to work in that environment, not any pastor or rabbi or leader in the church is qualified to do so. That's the first thing. The second thing is for us as chaplains, we have training programs through the International Conference of Police Chaplains as a wonderful program. The Billy Graham Association has a wonderful training and certification program. And so to have a chaplain then go through the proper certification and training, our division requires that of all the chaplains. So there's a specialized training. I'm also CISM trained as well, and most of our chaplains are. And so we would go through, in fact, all of the training that the officers go through our training academy, all chaplains have available to us, and we have taken advantage of many of those. So yeah, I think finding the right person that is kind of has qualifications and that training and education that would line up to be able to speak to the very real needs that are on the front lines of first responders.
I think you said something very important about finding the right person. And I think that's important, not just in the chaplain area, but also finding the right counselor, because we've heard of instances where, somebody will go and they'll talk to a counselor and they'll say, yeah, I was on this call and this guy, committed suicide and this is what I saw. And then the counselor's like taken way back and they freak out. And then that EMS professional knows, you know what, I can't even share here because I've just freaked somebody else out. So yeah, I think whether it be in the chaplain area or the mental health world, finding that right fit is so important for our first responders. I think that's definitely key.
Candace, if I could speak to that, I agree totally. And what we want to allow for, even as chaplains, is to help channel or direct that individual that we're caring for to the proper resource. And which is a very important thing for chaplains to know, and anyone that's in the area of helping, whether it's peer support or whether it's a counselor or social worker. We all must realize that we are limited in our abilities, but we're part of a greater team. And part of our responsibility is to take that individual's hand and place it in the hand of somebody else in order to get them the proper help that they need. Sometimes they really need a spiritual direction, and they seek that, ask for it, want it. They have those questions. I'm the right person for that. Sometimes there's a deeper, and I can refer and even partner with EAP, where I have a role and the individual, the counselor within EAP, or I have a relationship with our peer assistance program, and we can have a connection there. And that individual will know that there's a partnership, so this person can have more of a holistic healing process and a path forward for vibrancy in life to be able to overcome some of those very realistic challenges.
Yeah, and I think what's already been discussed earlier from Yvette and Adina, how important it is to identify those resources in advance, to establish those partnerships. That way, as you're making those referrals, you already know who to call. You can call and say, hey, Yvette, hey, Dina, hey, this person, I have this situation, I want to refer somebody to you.
And you can take that one step further, and I know this kind of goes back to Robin's question about what can I do, is reach out to your local mental health and recovery board. There's one in every county in Ohio, and I'm thinking there's probably one in every county or parish across the country, and talking to the director about what it is you need, the specialization around first responders, and build that relationship. And you can even have a couple of those counselors come out to your meetings and do a class on self-care. We'd do a couple of things. It would be provide them with that educational piece about how important self-care is. And it would also start to build that relationship. The staff would get to know that person as someone they could trust and link them back. It would be so much easier for them to make that step into counseling, because it is a big step for someone to acknowledge that they need help, and especially with first responders, and make that step to getting the help that they need.
Yeah, that's definitely some great advice. And speaking of needing help and linking to help, I want to circle back to Dave real quick. Dr. Mabry, I know you and your wife spend a lot of time focusing on empowering others to strengthen their marriage. And we know that the divorce rate in EMS and the fire service is high. So how does what our first responders see on the job impact their relationships at home, and what advice do you have for them?
Yeah, that's a great question. Primarily, we know that the unique challenges of being married and being a first responder, and also having a spouse who is a first responder, adds additional challenges. And primarily because of being able to come home and come off of that being vigilant. So hypervigilance is set, and coming home from that, and it's always present. And so it's, for us, when we work with a law enforcement, EMS, or a fire couple, it's helping them process that unique challenge and doing it as a team. We'd also make the contention that you very well cited the divorce rates, but what we make an argument that sometimes it's, while we don't support divorce at all, sometimes it's the challenge of staying in it that happens in that relationship, and the negative impact that lives and exists within that relationship. So, and that could go for a very long time. Divorce is just one indicator of an unhealthy situation. So what we want to do is come alongside those couples and give them the tools by which to navigate the challenges. Think about it. Everyone who's even watching this podcast, as a first responder in one capacity or another, you have specific training in order to adjust to the situation that you're placed in. And your training kicks in, muscle memory kicks in when you're faced with that situation, we hope, right? And so marriage is, and your most important relationships are no different. What my wife and I try to do is train first responders to what are the skills that you need for this and most important relationship, so that muscle memory takes over, so that you can have a healthy and vibrant relationship. It's a very special call, and we say that to spouses particularly. We've just started in Central Ohio a first responder spouses support group, the chaplains have, and EAP has come alongside as well. This message then to them of, it's a unique call, but it is a special call that they have as well. And it's not just a call for their partner, but it's also shared with them as well. So we come alongside them with some special tools, and with it really helps that we can have the conversation about the unique challenges that face these couples. We don't have a generic message that we hope a first responder can connect with, but we have very specific conversation of, okay, what kind of tools, coping mechanisms do you have when you come off of a shift? And are you going to unhealthy practices? Are you balanced? All right, how are you handling those stressors? How is your partner, your children, how are they affected by those? So we try to equip them with tools, and then encourage the partner, the spouse, to be part of the solution, rather than saying, you've got to fix yourself, right? So we try to help it be a partnership, and embrace that special call that every first responder has.
Very good. Well, thank you so much, Dr. Mabry. We've really enjoyed having you here today. We'll circle back to you in a few minutes. We're going to start the resource wrap-up portion of the show and get everybody's final thoughts, okay? So number one, educate yourself and learn with your team on secondary trauma, PTSD, and other mental health issues. Bring in a speaker from your local mental health organization, or reach out to groups like Firefighter Behavioral Health Alliance that offer workshops for EMS departments and that are focused on behavioral health awareness with a strong emphasis towards suicide prevention. Promote resources that are available to EMS healthcare workers and their families.
Number two, don't wait until you have an emergency. Get some feedback. Number two, don't wait until you have an emergency or need to establish those relationships with those mental health providers. As we heard, it's important to build those up front, make the introductions, bring those folks into your organization, connect individuals in your mental health, in the mental health world, to your providers within your organization, and know the barriers in advance. There's some barriers sometimes to getting people connected to mental health services. So make sure you identify those. It might be an insurance barrier. It might be a resource, a waiting list. So make sure you're familiar with those. That way, as you're making those referrals, that you know what barriers are in place and you know what to expect.
Number three, look at starting a peer support group. If you have questions about how to do so, we can reach out to Dina and Tracy to get you some info.
Yeah, absolutely. So what we'd like to do now is we'd like to give our guests a chance to share any final words of wisdoms that they might have. And Dina, we'll go ahead and we'll start with you.
Thank you. Dr. Marbury said something that piqued my interest, and I think we should go circle back to it. He talked about hypervigilance, and I think that's something that all first responders, including healthcare workers, experience and don't understand. And I did not understand it well myself until recently. And having understanding of the hypervigilance roller coaster is so critical for us. So when we're on duty and we're on shift, we are in that hypervigilance because we have to be alert. We have to be on our A game. And with that comes everything that comes with it. Our personality, our eccentricness, our extrovertedness, our awareness of everything around us. But we can't live like that all the time. So if you look at this line and you're thinking about this hypervigilance roller coaster, so here's the line. And when you're on duty, you're up here. When you get home, you drop well below the line. And this is something that not all people experience. This is something that more first responders experience than anybody else, dropping well below the line to apathy, depression, disconnection, unwillingness to want to connect with your family, unwillingness to want to make decisions. When I learned about hypervigilance roller coaster, Dr. Kevin Gilmartin, amazing. But his book, Emotional Survival for Law Enforcement, is where he talked about it. But he talked about this thing called the magic chair. And everybody I've mentioned this magic chair to that works in public safety is like, yes, you get home, you sit in this chair, and you're immediately a zombie. Your loved one wants to talk to you, and you just are zoned out. You don't care. TV's on, you don't see what's going on. And it's really dangerous because naturally just sitting in that chair, it takes 18 hours to get over it. But then we go back to work and we're back up in that hypervigilance. Then we get home and we drop down. And it leads to so many relationship problems. It leads to depression, unhealthy habits. So just having that awareness of this hypervigilance roller coaster is super important because then it teaches us that, hey, we've got to be aware of it. We have to schedule activities with our family. We have to make sure that we're engaged with our family. And then something that I thought was just really powerful, and we all know about the benefits of physical fitness on mental health. But Dr. Gilmartin mentions 22 minutes of exercise a day will help bring you back up. So when you get home and you drop way below that line, get off your butt and do something. And it brings you back up. But just having that awareness, that understanding, I think is important for us because I think a lot of us have experienced it. And we didn't know what it was. We just thought that we were kind of ruined by the job. But it's important to know because it does destroy relationships. And y'all talked about divorce. And it's interesting to see how depression, apathy is linked with disconnection when that didn't have to happen if we would take a little better care of ourselves. I just wanted to circle back to that. Thanks for bringing it up.
Yeah, good thoughts, Dina. Thank you so much for sharing. We're going to move on to Tracy for final thoughts. Anything you want to share, Tracy?
Absolutely. It was something that David said. I wanted to bring home the point about having that spousal connection and bringing them in. One thing that we have on North Carolina Peer Support Team is a team for the spouses. And we encourage all of our members to bring their spouse to class with them and or the next time, so that they can kind of listen in and understand about the resources that are available for their spouse, but also for them as well. And from personal experience, having been with a police officer in a long-term relationship, having those miscommunications that we had were huge. And if we had been able to kind of like bring together those resources in a group, or even had that kind of counseling, I think that would have made a huge difference. And thank you so much for having us be here. And just want to say, hey, it's okay to say I'm not doing so good, especially nowadays with EMS and fire PD. The COVID is hard, and it's hard to keep going to work every single day. And it's okay to say, hey, I'm not doing so hot right now. I need a little bit of help.
Oh, great advice. I couldn't agree more. We need to do a better job of saying, hey, I need some help. And then we also need to do a better job of listening and paying attention to when our coworkers and our peers, when they're struggling, and just reaching out. And like Yvette said, hey, can I help you with something? What's going on? I see a change in you. Which I'm going to actually move to Yvette next to see if she has any final words for our listeners.
I think that, just the whole idea of building a culture of self-care into your workplace, and supporting each other in that self-care is so important. Whether, it's the leader of your workplace, or maybe, just a group of coworkers just taking an effort in taking that walk, as Dina said, or eating salad, or, the next potluck, trying to help it be a little bit more nutritious, a little less fatty and salty. And thinking about self-care and is a priority.
Yeah, absolutely. And, you see a lot of different workplaces, they do fun challenges where they're, I know where I work, we do a step challenge, or how many steps, and we challenge each other. And we've had some other fun challenges. So you can make that fun, getting people moving and getting people taking care of themselves. So thank you for sharing. And we'll circle back to Dr. Mabry for his final words on this topic.
Yeah, I think that one of the most important things is to validate what an individual is going through when a first responder is facing many of the things that we've discussed today. It's validating, first and foremost, is validating the experience that they're going through. And it's very real. What may feel very negative is not pushing that down and denying those feelings that are very real, and that experience, whether it's physical or whether it's mental, it's valid, their response. And so when we speak into that, and we don't say, come on now, let's toughen up, and which that's not what I'm hearing on the podcast here, but it's more of saying, hey, you know what? And that's part of our role as those of us on the front lines of helping first responders, is saying what you're going through is very real. For us with working with marriages, it's, hey, it's not a mystery why your marriage, your most important relationship, is going through this, but it doesn't have to stay that way. And you don't have to stay in this place. We validate what you're going through. Now let's work on what are some paths of healing, what are some more healthy places for you to live and breathe. And then finally, I heard this over again, so it's just to repeat it again, is that not only for organizations who maybe, and leaders who are hearing this today, set up the systems, and don't be afraid to set them up, including like a chaplaincy. I'm biased in that direction. Set up a chaplaincy for your program, for your institution, but also for individuals. Do not be afraid to reach out. There's a lot of there's a lot of pride in the industry, and I see it every day that I'm with officers, but it's officers that are able to step down, even in humility, and say, I need help. And so if one is listening today and struggling with that, the encouragement I would have is, hey, set the pride aside for your benefit and the benefit of those around you.
Very good. Thank you so much. We want to thank all of you again for joining us tonight. It was really great talking to all of you. And I'm going to say goodbye. My name's Robin.
And I'm Dr. Candace McDonald, and thanks for listening to Another Dose. Until next time.